Okay, I want to welcome everybody out to tonight's webinar. Grateful for you coming out to listen to what we have to say. Today I'm going to be presenting a bunch of new material. We're going to start with some initial cases that some of you that have listened to me before may have seen, just as maybe a 3 or 4 minute refresher, but then we're going to get into some pretty new material for me right away. What we're going to be working on is actually integration, not only for the mops but also for vibration, getting that integrated into the practice. So we're going to learn how we can increase our practice efficiency. We're going to talk about some techniques for the front office and the back office staff. We're going to talk about some marketing things and then some practice management issues also. By way of disclosure, I'm not employed by any dental company. I do own some stock in Propel. I don't think it's enough to make me a rich man, but you know, I wouldn't turn it down if they said so. No family members even in dentistry. I've consulted for a few companies. I tried to write the ones down that I thought may have a chance of popping up in this presentation. No photographs, video, or audio recording of this presentation. So let's start in right with the case. This is a case, the first case I published in ortho practice regarding Propel. It was upper and lower, you know, mild to moderate crowding, but the patient also had a half-step class 2. In these particular slides, I'm not showing the class 2. We were doing sequential distalization on the top and then resolving the crowding on the bottom. So this was 4 years ago now, I believe, and so we had 23 trays on the bottom, and I used micro-osteoperforations or Propel on her. And what we ended up doing was, with those 23 trays, we started changing the aligners every 3 days. And then on the top we had 43 trays, and we changed the aligners every 3 days, and I got started with this 3-day change protocol, and this was the first one. So we were actually able to finish this case in 4.5 months, completing all 43 of the trays and the sequential distalization with elastics. So through the research that I had read and through mostly my own clinical experience that I'm now trying to document with research, I feel very comfortable with doing Propel mops and changing the aligners every 3 days. In fact, recently one of the residents in West Virginia just finished a thesis project which I think has some interesting data in it about Propel mops, and hopefully we'll have that ready for publication before too long. But it's something that I feel strongly about, I believe in. I think clinically, in my mind, there's no question that this works, and I want to be as much of a leader as I can in trying to get the clinical data and research out there. And so with the Propel mops and Propel driver, we can really speed up these cases, especially in our Invisalign cases. Tonight's almost entirely going to focus on Invisalign, but we can use the Propel mops with braces also. So how do the Propel mops work? Well, we're iatrogenically traumatizing the bone. We know from Wilcodonic experience, which is this first picture on the left, if we do a corticotomy and iatrogenically traumatize the bone, we can excite the cytokines in the body, which in turn creates an increased cytokine and osteoblastic and osteoclastic activity, and this allows the teeth to move more quickly. We've got lots of good research on Wilcodonics that it can help increase the rate of tooth movement. The problem with the Wilcodonics and the surgical flaps and corticotomies is that it's quite invasive, very expensive. You know, a full mouth can be anywhere from $3,000 to $6,000 with the oral surgeon, and it's not really for the masses of patients. The Wilcodonics isn't something that you would typically do for a class 1 moderate crowding case. And so is there a way that we can bring this biology to more of our patients? And that really, as we transition over to the picture on the right, it's really a less invasive way to get that cortical injury and excite those cytokines and get more osteoclastic and osteoplastic activity. So we can actually make these dimples in the bone, manual osteoperforations, or MOPs. We like to call them dimples with our patients. And we take the propel driver and we make dimples into the bone, righty-tighty, lefty-loosey. So if we look at the bottom picture of the x-ray, we look at that the dimple in the bone, and we compare that to how much traumatization we have in the picture above it with the Wilkinonics, you'd think that we have more traumatization in the upper picture than the lower picture, and therefore we would get more of an increased rate of movement on the top. Actually, what I found in my clinical experience is I'm getting a pretty good, if not almost, if not the same, and maybe even better response with the propel driver is what I was getting with the Wilkinonics. And I think the reason why is because of the way the corticotomy is made in the bone. In the upper Wilkinonics picture, we're using a high-speed handpiece and a small round burr. That small round burr removes bone out of the tissue, and so it affects only a very small area. But when we use a screw and drive the screw in, we actually get lateral pressure into the bone, and that lateral pressure creates microfractures or microstresses in the bone, which can excite those cytokines and get that osteoclastic activity. I believe that those microfractures radiate out to about 5 to 10 millimeters, and so if we overlap several of those MOPs, we can actually activate a large area of the root in a very non-invasive manner and be able to get these teeth to move faster. So that's the entire basis of how we're moving the teeth. I didn't want to spend a whole lot of time on the biology and the science because that's been well documented not only in the journals but also in the webinars that myself and others have already presented. And so we can, in my clinical experience, I've been able to make a dramatic difference in how fast we're able to move the teeth with Invisalign and braces, especially Invisalign and MOPs. So here's another case where we have a deep bite, a midline shift, ectopic lingual lower right cuspid, and in this case we're going to place MOPs around the lower right 3, the lower right lateral, and then the lower left cuspid. And so here we are when we're done. We were able to significantly improve the deep bite, significantly improve the midline shift. In fact, if you look at the ClinCheck, the midline is exactly where I set it in the ClinCheck, so I achieved my goals there, and we're able to very nicely align that lower right canine. So lots of stuff that we did here on this case. This was 35 aligners, and with the Propel MOPs in just activating those 3 teeth, we were able to change the aligners every 3 days and finish this case in 4.5 months. The next few cases, next 8 or 9 cases, are sequential cases from 3 or 4 years ago that I just took and put before and afters into this presentation that I'm about to show, in the sequence that I'm about to show of with 3-day aligner changes, what we were able to achieve with MOPs. Here's another one. In this case, these lower lateral incisors are roots are distally tipped, hard for the Invisalign plastic to grab onto that teeth, so moderate upper and lower crowding. A patient like this would never consider doing Wilkinonics, likely, but she did choose to do the micro-osteoperforations. So here we are when we're done. Again, we change the aligners every 3 days, but she actually chose to start the Propel process on aligner 6. So the first 6 aligners at 2 weeks per aligner took us 3 months to complete. At month 3, we did the MOPs, upper and lower 2 to 2, or the dimples, upper and lower 2 to 2, and then we finished the next 30 days in the next 30 trays at 3 days a tray in 90 days. So in the first 3 months of treatment, we changed the 6 aligners every 2 weeks, and then the final 3 months of treatment, we changed the aligners every 3 days for the next 90 days. So we were able to finish this case in 6 months, even with those difficult laterals, with a nice finish. And that's just MOPs upper and lower 2 to 2, did the MOPs at month 3, First 3 months, 6 aligners. Last 3 months, 30 aligners, and we got a great result. Here we have a diastema and lower dark triangles. We removed the composite from the diastema, did lower IPR. The day that I took this middle picture, we removed the rest of the composite. We did the MOPS, and from the middle picture to the bottom picture, we had exactly 19 Invisalign trays, and from the middle picture to the bottom picture is exactly 8 weeks. We were able to get all of that space closure, close all of those dark triangles in just 8 weeks. And the roots look very nice, no problems with resorption. In fact, I've never seen resorption of the roots in any of my Propel cases, but we're working on 2 research projects to try and prove that. So one is a resident doing a project for me from a more unbiased standpoint, and another project is one that I'm just going to be working on my own, which may have the air of some bias since I'm presenting it myself, but I still want to advance that conversation. But what a great result here we got with 3-day aligner changes. Here's an anterior crossbite. So here we're going to Propel again, maybe that lower left lateral, that lower left cuspid on the top, or Propel the upper left 1, 2, and 3. Start changing the aligners out. Here's the finish that we got. I kind of tipped the head up for the picture so that it could show that we were able to get a nice finish with the occlusion. MOPS in those areas, 27 aligners. We change the aligners every 3 days, and we were able to finish this case in 4 months. A little bit easier case, so we're going to do some MOPS lower 2 to 2 on this case. We only had 14 aligners in this case. From first photo to second photo, we were able to finish this case in 8 weeks after the Propel. Another tricky lateral with aligners, and I found that the MOPS with these tricky laterals can help those teeth track better. So we did the MOPS upper and lower 2 to 2, and we started changing the aligners every 3 days. Here we are with a nice finish with the aligners and the MOPS at 3-day tray changes. This was 29 aligners. We were able to finish this case in 5 months with 3-day tray changes. We probably did the Propel somewhere around month 2 or 3 on this case. So this one's a little bit different. On the bottom we got some lower anterior crowding, so we're going to do MOPS lower 2 to 2. On the top we have some previous upper second bicuspid extraction sites that open back up. So on the top we're going to do MOPS mesial to the 6s, mesial to the 7s, and distal to the 7s to close that relapse space. Now this is the result that we got. We were able to close the molar space, line up the bottom crowding. This happened to be my ortho tech, and so we had 24 aligners. I told her to change them every 3 days. She changed them every 2 days, and we were able to finish this case in 8 weeks using 2-day aligner changes on this case. Little deep bite. In this case, we want to. Looks like the posterior teeth are kind of dipping in, so we'd like to get some expansion. Can we get some help with the expansion in the Invisalign using MOPS? I think so. This is our final result. We were able to open the deep bite, line up the lower crowding, get some posterior dental expansion. This was 21 aligners, 3 days per aligner. We were able to finish this case in 3 months with the deep bite correction, the lower crowding, and some slight posterior dental expansion. Here on the bottom, here's the final Propel rapid fire case I'll show you. Again, another deep bite case. Some pretty severe crowding on the lower. If we look at the overlap of the lower canines and the lower laterals, those are some tough movements. 4 aligners. Again, when we look at the middle picture, you can imagine his smile, his upper posterior teeth kind of disappear behind the canines. So we would really like to get some posterior expansion. So for him, we're going to do MOPS this time, upper and lower 6 to 6. So a more complex case, at least when we look at the number of dimples that we're going to be placing on this case. Here we are when we're done. We were able to nicely open the deep bite, get rid of the lower crowding, get some expansion. He had 35 aligners. There was no refinement. I offered to do a refinement. I thought we could maybe get this dialed in a little bit better, like with that lower left cuspid. He said, no, thank you, I'm done. He came in asking for Propel. He was a referral from another Propel patient, so he came in asking for it. So we did it on the first treatment visit, and with 35 aligners, we were able to finish this case in 4 months from beginning to end and get the fixed retainer in. So this is what we were able to do early on with the MOPS and with the Invisalign treatment with 3-day aligner changes. More recently, over the last 9 months to a year, I guess I would say, I've been working with the V Pro 5. So here's a V Pro 5 case. This is another Invisalign case. She had a little bit of a deep bite, little smile arc problem with the laterals and the centrals. She could use a little bit of dental expansion, in my opinion, especially on the lower. She's got this V-shaped arch. So we're going to use the V Pro 5 for her. So she did V Pro 5, 5 minutes every night. And my protocol for the V Pro 5 is that I have the patient change the aligners every 5 days. I've done probably over 80 V Pro 5 cases now at 5-day aligner changes, and they've all been tracking excellent at 5 days per aligner. So this is her finished result. Maybe could have done some IPR to get rid of dark triangles in the front, but she was very happy with the result. You can see that we got a nice change in the smile arc for her. So at 5-day aligner changes, she had 21 trays. We finished this case in 4 months utilizing the V Pro 5 aligners and 5-day tray changes. She did the V Pro 5 5 minutes a night. And you can see we got some nice upper and lower arch expansion on this also. Here's another V Pro 5 case that we did. This gentleman is out of the country, and I should mention on this last patient, I saw her for 4 treatment visits. So my treatment visits would be the day that we delivered the retainers to the day that we took the till the day we took the attachments off. So that would be delivery day, visit a month later, a visit a month later, and then 1 month later we took the attachments off. So that would be 4 treatment visits. Early on, I was seeing these vibration patients that we were changing the trays every 5 days, pretty regular every month. Now I feel very comfortable stretching those patients out 2 to 3 months on the recalls. This patient was interesting because he works out of the country, and so he could come in and see me on a limited basis, so I wanted to make sure we got good tracking. So he decided he wanted to try the V Pro 5. So you can see that some moderately lingualized upper right incisors and then the ectopic lingual lower incisors. Here we are when we're done. Again, we got a little bit of nice arch expansion, opened the bite up just a little bit, got those lateral incisors forward, very nice alignment of the upper and lower anterior teeth. This was a V Pro 5 case, 5 aligners, 5 minutes, V Pro 5 every night after he put the aligners in, and then he changed the aligners every 5 days. He had 22 aligners, and we were able to finish his case in 4 months. We did 1 visit to deliver. We only did 3 visits for him. The first visit was to deliver the aligners without attachments. I saw him 2 weeks later, so 3 trays later, we put the attachments on. Then he left the country. He went through the rest of the trays. The timing was perfect. When he came back from out of the country, he was just finishing his last tray, and we finished this case in 4 months with 5-day tray changes. So that's with the V Pro 5. So what I want to talk about today, now that we got an idea of my experience of what I'm seeing regularly with my patients with the MOPS and the V Pro 5, I want to talk a little bit more detail about how I implement it into my office. So we're going to break it into into two sections. We're going to talk about first implementation of the vPro 5, then we'll talk about implementation of the MOPS. Seems like the last year that I've been given presentations, I tend to do the MOPS first and run out of time on the vPro 5. So I decided to flip it up and do the vPro 5 this time so we can spend a little bit more time focusing on how I implement the vPro 5. So we're going to talk about the device specifications, patient instructions, the options we have for changing the aligners with my preference. Then we'll talk about pricing options, timing of sales, and then collections, because that's always a question that I get. So what are the specifications? Propel markets the vPro 5 as a high frequency device. The rationale behind, one of the rationales behind that is it's at 120 hertz to use the clear plastic aligners as opposed to 30 hertz. There's a little bit of discussion in, if you dive deep into vibration research, about low and high frequencies. So they have brought this device out as a high frequency device at 120 hertz as opposed to 30 hertz, and we're going to wear this 5 minutes every night with the aligners in. So the different pieces are, in the top right, we've got the mouthpiece, then we've got the oscillator. Those are two different pieces. That's important to know, because if for some reason either part of those breaks, then, for instance, if it rarely happens, but if the mouthpiece breaks, I keep 3 or 4 extra mouthpieces in stock, and so if there's ever a problem with it, I just hand the patient a new one, and it's not a problem. A flash drive, a wall adapter, and a charging cable comes with the kit. The front office assigns the device to the patient, does some work on the device. The Propel rep can show your front office how to do that, and then we can access the user usage data at the beginning of each visit. So we have the patient bring the oscillator in with them. They don't need to bring the mouthpiece in. We just ask them to bring the oscillator in. We keep a USB cable plugged into the computer at the front office. Every time a vPro 5 patient comes in, they automatically hand that to the front desk. The front desk downloads the data. We print a PDF of the bottom right screen, and we attach that to the chart. So when I am in the back office and I see the patient, it's already attached to the chart, and I can see immediately their compliance. Not only does that help me to explain why we may not be seeing results that we're expecting, but because the patients know that we're going to be checking every visit, I think that helps compel them to be more compliant with the usage of the device. The instructions that we give them, we tell them to use the vPro 5 at least once per day. Once per day is the recommendations from the manufacturer. I actually allow the patients to use it up to 3 times a day. So I say I insist that you wear it 1 time a day. If you want to do it a couple of extra times a day, they can. I've done some internal research, and I've actually partnered with 4 other orthodontists across the country. We have a pain study submitted to a journal for peer review, and in that article that's waiting for the peer review, we're able to show that we were able to decrease the amount of discomfort almost immediately upon placing the vPro 5 into the mouth, even 2-3 minutes after using it, and then every day there's less and less discomfort associated with the aligners when we implement the vPro 5, and that was clinically significant over the controls without the vPro 5. Hope to be able to show you that publication soon. But because of that, I have started offering the patients that they can wear it up to 3 times a day if they want to help decrease discomfort, or if we can get a little bit better aligner seating, then that's what I would like to see. I really market this to my patients as an aligner seater. If you can see on the lower right picture, the aligner is not quite seated all the way. With the V Pro 5, if they do that in the office, we can see that aligner seat all the way up, even right before your very eyes. So after the last meal of the day, we have the patient brush their teeth. They place their aligners for the last time of the day. We want them, because it's an aligner seater, we want the patient to have their aligners in before they place the V Pro 5 in. They put their aligners in, they put the V Pro 5 in, turn it on, and then it gently ramps up over 5 minutes. So they bite gently on the mouthpiece. We let the V Pro 5 run its cycle after 5 minutes. It'll automatically shut off, but over that 5 minutes it's going to gently ramp up to the full 120 hertz. After they're done, they clean it and they charge the device, and it's ready for the next use, and the aligner is fully seated. So how often do we have the patients change their aligners? Well, one approach would be to have the patient change their aligners every 7 days. Now, the new Invisalign protocol is to, even without any acceleration or aligner seating, to go ahead and give 7-day aligner changes a chance. There's a lot of doctors out there that aren't quite comfortable with that. So if you're a more conservative doctor, a more conservative approach, you could take the stance of, okay, we're going to go ahead and embrace this 7-day aligner protocol recommended by Align, but just to be safe, we're going to back it up with some aligner seating with the V Pro 5 to make sure that we're getting the aligner seated all the way. So the doctor is hoping to get fewer additional aligners on refinements because we're getting better aligner seating. The other option would be to do 5-day aligner changes. Now this is what I personally do in my office. I've got over 80 patients treated at 5-day aligner changes with very nice tracking, no problems with those patients. Especially if they're being compliant and wearing their trays. What I'm also suspicious of is that even the patients that may not be wearing their aligners the full 22 hours a day, we may still be getting by with that because we're getting the aligner seating. I think that's a very interesting area of research that someone could pursue. So I also like the 5-day aligner changes because it's easy to remember. It's the V Pro 5, so 5 minutes per day, 5 minutes per tray. It's kind of ringy, so it's easy for the staff to remember, and I like things that are easy for the staff. 5 minutes per day, 5 days per tray. So like I said, I consistently have excellent tracking at this rate. Another option would be 3-day aligner changes. I haven't yet embraced 3-day aligner changes with V Pro 5 on its own. To be honest with you, I haven't tried it. I have done 3-day aligner changes with V Pro 5 if I'm also using the MOPS. So if I do MOPS, I would be doing the 3-day aligner changes anyway. But I may be able to get better aligner seating, therefore better tracking, possibly fewer refinements or fewer additional aligners because we're doing both. So that's an option. So if I'm doing both, I do 3-day aligner changes, and I've actually got several cases where we've been quite successful in seeing amazing things where we've implemented both the MOPS and the V Pro 5 and done 3-day aligner changes. So how do I price this? Well, I actually right now am doing the option in the middle, the value. I'm getting ready to switch over to doing the first column, which is included with the treatment. So let's go through these columns one by one. Now, just to be clear, I don't think that you should be doing all 3 of these options at the same time as a strategy, because I think that would lead to confusion for the staff, confusion in scripting, and a less unsure approach as we're explaining to the patient. So I think we should go through each one of these options included with treatment value or premium, and then you can kind of think about which one fits best into your practice at this time, implement that, and then over time you may want to change it up based on what you're seeing. So the first option would be included with the treatment. I really think that when we included with treatment, this is for the doctor that is convinced of its effectiveness and its profitability. You're probably not going to do this unless you're absolutely convinced that you're getting amazing results with it, because you would be paying for the device and giving it to every Invisalign start that you have at no extra cost. So the good news is every patient gets it. And because every patient is getting it, you're going to be doing lots of Invisalign that way. You're going to be ordering lots of the V Pro 5. So because you're buying it in bulk, you're going to be able to get it at the cheapest price per unit. So that would be one of the advantages of doing it this way. This would also be for the price competitive doc. So you're not going to charge extra, and you're hoping for decreased chair time, allowing an increased volume with the same price or a decreased price. So if you're in a market to where it's very competitive and you want to find a way to be able to lower your price, you could implement the V Pro 5, give it to every patient, because you're hoping that the trays are going to track better, you're going to be able to see the patient less. It allows you the opportunity to see a higher volume of patients and therefore decrease your price with less overhead. So that would, if you're in that market, that would help you that way. Or if you're already at capacity, then you could, in this model and making those assumptions, you could be able to open up some chair time so that you can bring some more patients in while keeping your price the same rather than lowering your price. The profitability is based on practice efficiency and competitive posturing. So again, if your market is kind of forcing you to lower your price, you can implement the V Pro 5 as a strategy to help with that. Or if you're in a market to where you really don't want to raise your price, but you're at maximum capacity, this would be a way to accept new patients and increase your revenue. The middle option would be the value option. So in this case, this is really for the doctor to where the doctor has a lot of patients who are coming in to see the doctor for the first time. It's a first touch between the doctor and the patient. There may not be a whole lot of rapport there, and so therefore the doctor has to convince the patient of the value of the V Pro 5. So you have to go through some scripting to explain to them why the V Pro 5 is important. Again, you're not really wanting to give it away for free to every patient, so the patient's going to have to pay extra for it. So they're going to have to be educated as to the value. And so for this, I charge $400, and this covers the cost of the device with a moderate volume, so you don't have anything out of pocket. And this is a great strategy when you're first starting with the V Pro 5 to really get ramped up, because you don't have to have a whole lot of outlay up front and a whole lot of cash flow out front, and you can work to a higher and higher volume. So it allows for growth of the vibration portion while managing cash flow. In this case, profitability is based on increased practice efficiency. That's what we're banking on. The other option would be more of a premium option. In this case, the patient is already convinced of the doctor's expertise. The patient is coming in because it's clear in the community, or it's clear from internal referrals or friends' referrals. The majority of the patients in this practice come to this doctor because this is the doctor to go to, and they wouldn't think of going anywhere else because of the doctor's expertise. So they're willing to pay a premium for that expertise and that and that experience, so the patient's willing to pay more for the increased efficiency. And in this case, you can charge a premium. You can actually directly profit off the sale of the vPro 5 in this case, and depending on the market, you could charge anywhere. I think a reasonable fee depending on the market would be $500 to $1,200. Maybe in the big metropolitan cities like New York, maybe $1,200 may be appropriate for this type of doctor in that type of market. In this case, profitability is based on direct profit rather than indirect profitability because of efficiencies. Now, because this is a special situation, the doctor in this practice may be a doctor that has this rapport with the patients and would maybe like to get some more chair time so they could take some more time off, or maybe they want to start another practice, or lots of different reasons about why a doctor in this position may choose to also want to get the indirect profit from these cases also. So those are kind of the practice strategies that the pricing strategies out there. Now, the premium really doesn't work in my demographic. Although, you know, pat myself on the back, I do think I have a good reputation in my area. I still get quite a few patients that are coming in on maybe second or third opinions. And so I would have to do some convincing for them to get to the point to where we could charge that premium price. So I initially have felt more comfortable in the value proposition to where I offer it to the patient. They can choose to use it or not use it. If they choose, if I convince them it has value and they want to do it, they pay the $400. Now I'm transitioning, because now I'm so convinced of the effectiveness and the profitability because I've done so many patients with it and I see how great it is. We're transitioning the practice over to where we're just going to include it in the cost of the treatment, because I no longer want a patient to say no. I feel like if a patient says no to the $400 and they don't do it, I end up losing money because we're not as efficient. So I'd hate for them not to do it because they didn't want to pay. I would end up losing money, so we're going to go ahead and give it away for free. Now there's the timing of sales. This is important too. When do you bring it up? Do you bring it up in the initial consultation? Do you bring it up during treatment, or do you bring it up after treatment? Well, it depends. I typically bring it up in the middle of treatment, but there's some times to where I bring it up in the initial consultation. Now, if I'm bringing it up in the initial consultation, I'm wanting to differentiate my practice over the other practice. So let's say a patient's getting 2 or 3 referrals. So they come into my office, I'm wanting to differentiate, so I want the patient to know we're doing something different. On the flip side of that, based on how you script it, by offering new information, you may also be overwhelming the patient. So you need to be careful that you're not overwhelming the patient if you're trying to differentiate your practice. If you've done marketing for the vPro 5, maybe on your website, maybe with flyers, patients may be coming in asking for it. So obviously if they're asking for it, if they're referred from an internal referral source, we're going to go ahead and bring it up in the initial consultation. You can see here the doc locator site. So Propel is trying to help us out with the doc locator. So when you become a customer, you also become on the doc locator screen. That's what we see on the right. Now we can also bring it up during treatment. In this scenario, because we're not bringing it up in the initial consultation, but in treatment, the doctor's already built a relationship of trust. So I can tell the patient, hey, I think this would really be helpful, because now we've grown that relationship of trust. They're more likely to say yes. Because the contract is already signed in this scenario, they're less likely to ask me for a discounted treatment fee. So I think that really the ideal time to do this, so that we have the opportunity of building rapport and we still get benefit from the appliance, I think during the first third of treatment is a great time to add this in. We can also add it in during treatment for lack of tracking due to difficult movements or compliance. So maybe we need the aligner seater component. We see that the patient's not wearing their aligners well, or we've got a difficult movement, so we want to increase the amount of tracking. They don't want to do MOPS, so let's add on the VPOR 5. Another way that I've really seen a benefit of adding this on during treatment is when we would have to order additional aligners, like a mid-course a correction to prevent backtracking. So this is a perfect case for that scenario, to where we had poor compliance. Here's the issue. This patient is a half-step or full-step, half-step to full-step class 2. We're going to start her with the carrier motion class 2. So we start with the motion device. 3.5 months later, we're able to go from the half to full-step class 2. In 3.5 months, we developed a class 1 platform using elastics with the class 2 motion device. Now, what I decided to do on this patient was to go ahead and do an intraoral scan this day with the appliance on, and then I have Invisalign virtually remove the motion appliance for me, or the distalizers for me. So we're going to scan it in this way. They're going to digitally remove those and make the trays. That works like a charm almost all the time. We take it off, they come back. Sorry, we leave it on, then they come back the day of tray delivery. We take the appliance off, and then we give them the trays, and they fit perfect. Well, in this case, I told the patient to come back 2 weeks later. We expedite these cases, by the way. I told her to come back 2 weeks later, and she disappeared for 2 to 3 months. So she disappeared for 2 to 3 months, and we tried to put the aligners back in. So now we've got a problem. What are we going to do? She can't even get the aligners to fit. It's hurting. So what's the option here? Well, the option is a mid-course refinement or a warranty, or whatever you want to call it. We're going to have to take a new scan. We're going to have to take an upper impression. We're going to have to fabricate an Essex. We're going to have her wait in the lobby, or come back an additional visit, additional chair time to deliver the Essex while we're waiting on the new aligners to come back, and then a new visit for the new aligners. So that could cost me 2 or 3 additional appointments. It's going to cost me more chair time, more disgruntlement from the patient, and then I'm in this situation, the child's going to be in trouble, and I'm going to feel the urge to reprimand the patient, and that's not going to do anything good for future referrals. So this problem could end up costing me $400 to $800 because of all those issues. For this patient, what I decided to do instead is decided, you know what, no problem. I could actually charge you for the non-compliance for this, but I would rather not do that because we like you. I've got a solution. I've got this appliance. It's called the VPRO 5 that can help the aligner seat. Normally we'd sell it to you for $400. I'm just going to give it to you today. Remember, I'm thinking in my head, I'm going to lose $400 to $800 on this anyway, so it'd be much easier for me just to grab the device off the shelf, give it to the patient. I only spent $250, $290 for it at bulk, and then the patient puts it in their mouth, and we fully seat the aligner that day. It's not hurting because of the pain reduction that I talked about previously with my study. And so that's what we did for the patient. And then without having to do a refinement, we were able to get the aligners seated very, very nicely. And then this is 6 months with aligners with the VPRO 5. The added benefit is now, because we've given her the VPRO 5, we've turned lemons into lemonade. Now we're changing the aligners every 5 days, and mom couldn't be more happy. We definitely earned points in the future referral category, and we took that bad situation and made it a great one by using the aligner seater to avoid the mid-course correction. So that's one way that we can implement it during treatment. I have found that there's also a place for this post-treatment. What about poor tracking retainers? Look at this case. I think that this is a great looking case. I mean, I look at this. This is a great finish for me. This was a traditional treated case. The patient parent chose to do Vivera retainers. This was not vibration or mops. You can see maybe on that lower right central, it's a little bit rotated out. So mom paid for Vivera. She paid me $650 extra for Vivera. We give the patient the Vivera. Do you think this guy wore his Vivera? Well, I can tell you he wasn't very compliant with his retainers. So a year later, he comes back to me, and this is what we had. So 1 year later, he's got this lower relapse and the Vivera that he paid $650 for. He can't even get it on. He's got a tear in his eye to get the aligner on at this point. So what do? The patient's paid $650 for Vivera. If we retreat this or do any of the other options like taking the lower Essex, doing resets on the cast, making extra retainers, Invisalign Express 5, red, white, and blue, all these different options that we do, well, first of all, the patient's going to have to pay for that, and second of all, they still have to pay for new Vivera retainers when it's all done. So in this case, I said, I'll tell you what about if instead you give me $200 instead of doing that retreat? How about you give me $200 and we see if we can treat this with the V-Pro 5. So they agreed. They gave me $200 because I wanted to meet them in the middle on this. And I told them, hey, let's give this a try. If it doesn't work, you'll still have it for during the retreat. And so here he is when the patient left the office. Remember, this is the highest, the most that he could get it on with a tear in his eye. We did the V-Pro 5, and he left the office with the aligner seating like this in no pain. And so that, in my mind, was a great use of the V-Pro 5. Here he is 4 months later. I've added saw him once in between to add some dimples in on that tooth to help it come in just a little bit better. And after 4 months with the same Vivera retainer and with the V-Pro 5, we were able to get him back to where he started for only $200. That is essentially what he would have had to pay for a new retainer anyway, much, much less than he would have had to pay with refinement. And here we won future referrals rather than lost referrals on this patient. So an interesting way to use the V-Pro 5 post-treatment. What about retreats? If we need to retreat, no one that wants to do a repeat wants to be in their aligners for a long period of time. It's a retreat, so we already have problems with compliance with aligner seating. So we can, if I was retreating someone with Invisalign, or with a second refinement, so kind of a retreat / refinement now that they're free, I would almost always add a V-Pro 5 to help with better aligner seating in the retreat. What about better bone density? Well, that's a big question, and I don't know for a fact whether or not having better bone density with V-Pro 5 helps with better stability, but I did have an interesting research project that is submitted for publication. In this case, we had several V-Pro 5 patients versus several control patients with just Invisalign alone. The conclusion was with the V-Pro 5 with Invisalign, it allowed earlier aligner changes in the experimental group that led to shortening of the treatment time, and we had an significantly increased bone density around the teeth that we treated with the V-Pro 5. So I'm going to have to really run through this research article. So essentially, we measured the bone density on CBCTs. So I don't want to spend a lot of time on the methodology on this. It'll be published soon. So we had a uniform way in which we measured the bone density, and then before and after we measure the bone density using the CBCT. And then this is a typical patient with the V-Pro 5 with 5-day aligner changes. This was a typical patient with 10 to 14-day aligner changes without the V-Pro 5, and what we found is that there was a shorter treatment time in the V-Pro 5 cases with the 5-day aligner changes. Not only that, we had better bone density in the after patients with the V-Pro 5 than we had with the non-V-Pro 5 patients. So again, we can see that post-operatively we had a higher bone density after treatment with the V-Pro 5. So that was the HU units with the V-Pro 5. Again, this is submitted for publication, so we'll see what happens with that. But I'm suspicious, based on the research that I have, that we get better bone density from the V-Pro 5. I'm curious whether or not that may lead to better retention. Anyone out there that wants to tackle some of that research, give me a call. What about collections? Now this is the question that I always get. If you're still asking this question, you're not following the orthodontic market. What's the question? Well, how do you get the patient to pay? If you're finishing treatment faster, how do you get the patient to pay? Well, if you're asking this question, then you're basing your collections on treatment time. And if you're doing that now, the market is not going to allow you to do that much longer. Corporate dentists, other orthodontists are lowering their down payments, extending their payment plans beyond treatment time, and in corporate dentistry, the patient's paying them. In the private practice orthodontists, the patients are extending the payment plans, patients are paying them. The same is true with accelerated treatment. Because we live in a credit society, sorry I lost my thought for a moment, because we live in a credit society, if we base our collections on treatment time, we're going to lose a lot more money in potential sales than we would in the amount of money lost in default collections, period. And I could spend more time talking about that, but it's just the truth. And it doesn't matter whether you believe it or not. The market's not going to allow you much longer to follow a different strategy. You're going to have to allow the patient to pay over a longer period of time than what treatment is. That's just the bottom line. So here's some tips to make that happen. You can use third-party financing. Obviously, that's the easiest way to get your money right away if the patient can get approved. If they can't get approved, you can do automatic drafts. That helps get better collections. Always build value into your retention. How about if the patient has a V-Pro 5, that is building more value into the retention. I ask my patients to wear the V-Pro 5 an additional 6 months into retention. Look into Sliders. Sliders is online tools to where the patients can use a slider on the screen to kind of choose their own down payment, kind of choose their own payment plan. Or you can just ask the patient what they can afford each month and then say, okay, if you can afford $180 a month, then it's going to be this many payments. You need to be lowering your down payment. Remember, you don't have to collect your upfront costs from the patient, because in today's society, most patients are going to get an insurance down payment. Even if they drop out within the first month, we're going to get enough insurance coverage usually to cover our costs. And finally, be nice. All you have to do is be nice. If you're super nice to people, they will pay you. People pay the people they love. If you're a jerk, if you made the patient mad, that's when they stop paying you. Okay, let's real quickly now, we're going to flip this around today and spend less time talking about implementation of the MOPS. So here's the steps for implementation. We all know this, so I don't want to spend a lot of time on it. We're going to evaluate the treatment area, palpate the tissue, chlorhexidine rinse twice, and then anesthetize and accelerate. Look at the x-ray to make sure we're not going to hit vital structures, and then we're going to choose where to perforate. And since I'm going to be going through this fast, I've got lots of, at least 2 or 3 webinars where we've talked about this. So ask your Propel rep for a link and you can look at those webinars where I go in more detail about where to perforate. plan it out in advance and mark it down on a sheet using this, like this, so that the assistants know where to place the topical. Now we have two options for anesthesia. We can place topical with BTT, or we can do local infiltration. Most orthodontists are using topical with BTT and having very good success with that. A minority are using local infiltration with Septicaine and getting great success with that also. This is not how I place topical. This is my tray set up for placing topical. I'm not going to squirt the topical or the BTT directly into the patient's mouth. I'm going to squirt it on to these gauze strips. We're going to put an ample amount on. This would be the length for 5 to 5. This would be the length for 3 to 3. We're going to put the cheek retractors in the mouth and then lay the tissue on the gums depending on how many teeth we need to numb up. We're going to make sure the tissue is dry, cut the gauze to size. The assistants can do this because I've already planned out and charted where they're going to be placing it, so I can still only have one visit to the chair. They're going to remove the gauze after 3 or 4 minutes. They're going to dry wipe it out, then rinse it. Now we don't want to do the propel right away after we rinse off the gauze because they don't have full anesthesia yet. Enough topical has soaked underneath the gum tissue that we're still getting a pharmacological effect even after we rinse it off, but it's going to take about an additional 10 minutes to get full anesthesia. So be patient, don't do the propel right away, but you don't want to waste that chair time. So during that chair time, we want to go ahead and do the mechanics of the day. So here's a case where we're going to be using topical. We're going to place the topical on, then we're going to do propel around the upper right canine for a bootstrap. Now here the gauze is too big, so that's not the right way to do it. It is right to use the gauze, but the gauze is too big. You can also see that the gauze is soaked, so we didn't have cheek retractors in. The gauze is soaked with saliva, which means the topical is diluted and it's all over the mouth, which gives a bad experience for the patient. Well, one thing done right here is we rinse the topical off during that extra 10 minutes. We do the mechanics of the day, which is putting the bootstrap on, and then we do the propel. You can see in this slide, this is my first propel, but you can see the tissue is kind of raw. That's because they left the topical on too long and we get what's called tissue sloughing. The topical was probably left on 5 or 6 minutes. We don't want to leave it on that long. We want to make sure we set a timer and remove it after 3 minutes so we don't get that sloughing. And then we do the propel around that tooth. In this case, I did 3 mops distal, 3 mops mesial of the canine. We're going to bootstrap it down into position, and that tooth came down in 2 to 3 months with the mops and the bootstrap. So last time the gauze was too big, this time it's too small. But I do want to make a note that this would be the right size gauze if we have done the strips to begin with. We're getting good anesthesia, but we might hit a spot on the patient to where they feel it a little bit. Well, we're going to immediately stop in that area, and we're going to have some of these little tiny pieces of gauze pre-made, so as we're doing the mops, if we have an area where we didn't get good anesthesia, we're going to immediately stop the mops in that area, place this little patch over top of it, continue on to another area to do more mops. 3 minutes later, we'll wipe that off and come back and redo the propel in that area, and on that second go, the patient's going to be plenty numb, and that's what that would look like when we go back and do the retreat if we didn't get good anesthesia the first go around. Here we are doing the mops, 3 mops mesial and distal of those teeth. So if you want it done right, you got to do it yourself. This is me. This is the way it's supposed to look. This is the most numb I've ever been in my life, just with topical anesthesia. I had one of my friends do this for me. This was my first propel mops experience where I'm getting mopped. We've got the driver stuck in there, a full 7 millimeters. I was able to get numb enough that I didn't feel a thing, even with it 7 millimeters. Remember, you only have to be 2 to 3 millimeters in bone but we went ahead and did the full 7. I didn't feel a thing here. We even let go of the device, and I didn't feel a thing. So if you're methodical, you can get good anesthesia. An hour later, we were eating ice cream, and I was feeling just fine. So this is me doing Propel on the patient. Unfortunately, I don't have good audio on this, so I'll have to tell you. I asked her, "Hey Becca, how you feeling?" She says, "I feel fine, no pressure." Yep, just a little bit of pressure, but I'm not hurting at all. It's fine. So this is 2 to 3 millimeters in the bone, and she's feeling just fine. Righty-tighty, lefty-loosey. Now, I wouldn't recommend letting go of the device. I never do that, but it sure did make for a good video, didn't it? Don't try that at home. Here's another one with the power driver. We're going to go in. It just takes a couple of seconds to get to 2 or 3 millimeter depth. Then we hit reverse and back it back out. That's placing one mop with good anesthesia. You can see here that the patient's very numb. She's not feeling a thing, and this is with topical anesthesia only. Here's another patient. Now, if you have a difficult area where you're trying to place the mops, look at my hand technique here. I am got my left index finger on the palate, and then I've got my thumb on the head of the driver. I'm doing a squeezing action with my fingers to help squeeze the driver into the area. So if you have some tough bone, this is a technique that you can do to get it to drive into that area. Watch the patient. She's hitting the reverse for me. She's got gauze in her hand so that she can wipe the area as we're moving along. She doesn't have to wipe it very often. Maybe every 4 or 5 teeth she has to take the gauze and just dry wipe it out. I talked about planning of perforations in a previous presentation. I'm going to go through it real quickly here since we're out of time. Again, if we're only placing one mop, I like to do it right at the mucogingival junction at the center of resistance of the root. If I'm placing 2, I like to place one above the mucogingival junction, one below. If I'm doing a bunch of teeth, this is my typical protocol. If I have a tricky canine, sometimes I'll add a 3rd mop towards the apex for those teeth. Another trick to help us learn where to place the mops is to use this treatment sheet from Invisalign. So here the black teeth are the advanced movements. You might want to put 3 mops around those advanced teeth. On the moderate teeth, you might want to do 2 mops. That's just a couple tricks that you can use to help decide where to place the mops, and then of course look at the clean checks. Here are some scripting tips. So here's some things you want to avoid. You don't want to say micro-osteoperforation. You don't want to say screw. You don't want to say cytokines. You don't want to say osteoclast. You do want to say things like dimples or dimple days. You want to say things like place dimples underneath the gum tissue. You want to say things like tap the bone or wake up the bone. We want to stimulate the bone to change shape faster. We want to numb the gums with numbing gel. See, we're using softer language to get the same point across that the patient can understand without making it too scientific and too scary. We can get informed consent with using nicer, softer language, and the best people to explain this to the patient are the assistants, not ourselves as the doctors. So here's the scripting. Well, you should be pretty comfortable while we're doing the procedure, but you may be pretty sore for a few hours after the numbing wears off. You don't want to, you want to build an expectation. For some patients, they may be a little sore. A lot of patients, they're fine, they have no issues, but you don't want to tell every patient, you're going to be fine and not feel a thing. So for most patients, I tell them, some patients may be pretty sore for a few hours, but it's going to go away, and it's going to be worth it. Just in case you're one of those who are pretty sore after, you may want to take the day off work. So I don't want patients to come in for Propel in the morning and have work scheduled just in case they're one of those patients that are sore. Some more scripting tips. How do I approach the patient with it? Now, this is me talking to the patient. How would you like to change your trays every 3 days instead of every 2 weeks? Their response is going to be, really, I can do that? How? And then my reply to them is, well, we do have to do an extra procedure called Propel. I'll have Jane, the assistant, come over and explain it to you. That's as much as I want to say, because if I start explaining to it, we're not going to get good informed consent, because I have a hard time not making it too scientific. So the assistants can actually do a better job with the previous scripting, explaining it to a patient in a way that they understand and in a way that they can get excited about it. They may say, well, how much? And then in that case, as we talked about, I use that value version that we'll go over in a minute. I say 200, you can pay today or you can pay next time. Usually they say, fine, that's great. Sometimes they say, oh, you know what, I'm kind of on a tight budget right now. I'm working at Hardee's just to pay my monthly payment. Oh, that's okay. I understand. We could just extend your payment plan an extra payment or two. So we could just extend the payment plan a little bit longer, and that could be a way to get this implemented. We may also want to say something to the effect of, we may be able to bill your insurance for a little extra. The financial coordinator can check on that up front for you. Maybe some scripting for braces instead of aligners. Wow, your teeth sure have lined up fast. Isn't that awesome? The teeth actually unravel pretty fast at first. The next 2/3 of your treatment, though, it may start to slow down. I just want you to know that there's a way that we can keep it moving twice as fast. Some scripting for braces patients. Or the patient may ask you, how long till I get my braces off? We hear that all the time. The answer is probably be something like, actually, you have about a year left. But you know what? There's a way that we could get them off faster. I'm going to have my assistant come over. She's going to explain a procedure we can do that may be able to help get them off faster. Wow, that canine still looks rotated. I know you're frustrated, so am I. That tooth sure is stubborn. That bone's really tough. You know, there's a way that we could stimulate the bone to move things faster. How about in the initial consult? So the patient asks how much. So my reply is, actually, it's an $1,800 procedure. But since we'll finish faster, I will save some money. I want to pass those savings on to you, so we're only going to charge you $200. You see what I've done here? I've built value into the procedure. I become a hero and let them know that we're doing it cheaper. And also I'm avoiding the next question, which would be, well, do I get a discount if we're finishing faster? Well, I've already told them that the discount is already included in the cost of doing the procedure. Oh, 18 months is too long because of a wedding, movie, photo, etc. Actually, we have a way that we can cut that time in half. It's a little bit more because we have to do an extra procedure. After I leave, the TC can tell you all about it. Do you see what we've done here? We've started out by telling them it's more right from the front, so they don't follow up with the question, do I get a discount because we're finishing faster? So the pricing options, this is pretty much the same as with the V-Pro 5. In the first, included with treatment, the doctor's convinced of the profitability. In the value option, here it's a little bit less because the screw's only $100, $120. Remember, we might get some insurance from the dental insurance on this. We'll talk about this in a minute. So that $200 can help cover the copay for the dental insurance. And then there's the premium option. In this case, we charge $500 to $1,800 depending on the market. Now, some practitioners have had success submitting this to dental insurance. The codes that they've been successful with is 7320 or 7321. Both of these are vilioplasty without extraction. The first one is 4 teeth or more. The second one is 1 tooth or less. What's the UCR? Well, what would an oral surgeon charge? If an oral surgeon is doing this, they're going to charge at least $1,800 to do this procedure. They're not going to do what we do for $200, guarantee, if an oral surgeon is doing it. So what's a fair price for this? Well, it's what I said before. In the initial consult, it's $1,800. So our UCR fee that we're going to put into this is going to be $450 per quadrant. So what do the insurances usually pay? Well, just like anything else, we don't get the UCR fee, we get something less. And in my practice, it's usually somewhere between $125 to $250 a quadrant. Now, we always want to charge a copay. That's important when we're charging insurance, but we also don't want the insurance company to think that the alveoloplasty is in conjunction with doing a denture. So we want to make it very clear what we're doing because we don't want them to come back and say that we committed fraud because we were submitting a denture code. Well, this is not a denture code, it's an alveoloplasty code, and in my opinion we can use it in some markets for alveoloplasty, but I want to make sure the dental insurance company understands crystal clear what we're doing. So we're always going to submit a picture to the insurance company of the perforations, the bloody holes where we did the perforation. So they see we didn't lay a flap, that we didn't trim down the bone. In fact, we did mops. And then we're always going to check the box for the procedure that this is associated with orthodontics. And then in a notes section, there's a notes section on these forms, we're going to be very specific. We placed osteo-perforations in the alveolus using the Propel, all caps, Propel device for the sole, all caps, purpose of orthodontically moving the teeth faster. So we want to put that in there so that it's crystal clear with the insurance that we're doing this for orthodontic purposes, and if they want to pay, we're happy to take it as long as it's all above board and we know what we're doing. So this is the final case that we're going to finish with. This patient is a class 3 case. This patient came in because the parents were in the dental industry. They knew about carrier motion class 3 on this class 3 case. They knew about MOPS. They knew about V-Pro 5. They knew about Invisalign. They came asking for all 4 of those. So here we are with the motion class 3. Don't have time for a whole lot of details here. I actually ended up, and I can explain this on a different webinar, I actually ended up why I did this, we switched to the 4 to 6 instead of the 3 to 6 because I didn't want to get extrusion of the canine on this case. So 8 weeks later, we were already a class 1 molar, but I wanted to overcorrect it. So we decided to go ahead and do MOPS in order to help us overcorrect it. So we did MOPS, 2 MOPS, 1 above the mucogingival junction, 1 below on all of those posterior teeth. So we use those MOPS to help facilitate the distalization of those lower posterior teeth. She came back 6 weeks after the Propel, and then now after we did the Propel, she is now a full step class 2 molar and a full step class 2 canine. So we got amazing results with the MOPS along with the carrier motion class 3. We can see the dramatic change that we got in the profile with that class 3 motion, and then we submit it for the ClinCheck. check. In the ClinCheck, check, I want to do a bite jump because we're going to get a little bit of relapse because we always want to overcorrect it and plan for relapse. I'll show that again. I don't want to necessarily bring the bite together too much. I just want to level things back out. The bite will close up on its own. We'll get some spontaneous relapse on its own and hopefully end up in a perfect class 1. I added in some backup elastic hooks just in case we didn't get the full amount of relapse that I was expecting. That way I could run some class 2 elastics to bring it back to the full class 1 if we needed to. Turns out I didn't have to add those class 2 elastics back on. This patient was completed with no elastics after the carrier motion was approved. So we implemented the carrier motion class 3 Propel MOPS, and now that we gave her the Invisalign aligners, we give her the V-Pro 5. She changes the aligners every 5 days, and she goes through the first set of aligners at 5 days per aligner. It's not quite socked in perfectly, so we're going to do a refinement. My refinement for her was 12 additional aligners, 5 days per aligner. That's going to be 1 visit in 60 days. So I asked her to come back to the office in 60 days after the refinement. This is how she came back after the refinement. Really nice and socked in after the refinement. A perfect class 1, a good smile arc, and now all she has to do is have the bonding of her peg laterals. We chose to have the bonding of the peg laterals done because eventually she's going to need veneers all across the front because of the discolored enamel that she presented with initially. So again, this is a way in which 7 months total treatment time. So this is a way that we can take that class 3 Invisalign case, implement different strategies to be more efficient and finish it faster. We implemented several things. The motion class 3 to take her from the class 3 into a class 1 and even overcorrect it. We used the propel to help in the effectiveness of the motion class 3, and then we used the V-Pro 5 to help us seat the aligners better, and she got an absolutely fabulous result, a beautiful change in her profile, and now when she's a little later in adolescence and she does the aesthetics on the front, it'll be absolutely gorgeous. So that's the end of the presentation. Thanks for hanging in there just a little bit longer. So now we're going to go ahead and head to the question portion of this. So I'll say a few ending remarks while I wait for people to start asking questions. So to ask the questions, just type them in and I will answer them as I see the questions. So I got congratulations from Dr. Ramos in Brazil, leading the way in Propel in Brazil. So thank you, buddy. I appreciate hearing that. While I'm waiting on more questions, I want to show this my Facebook page. It's Acceleration Ortho Station. The easiest way to find it is to just go onto Facebook and search Acceleration Ortho Station. Ask to join the group. As long as you're an orthodontist or an orthodontic resident, I will accept you to the group. If you've got privacy on your Facebook page to where I can't readily see that you're an orthodontist or an orthodontic resident, I do have someone vetting these applications to be a member. So maybe just send a private message saying that you are an orthodontist and we'll accept you into the group. Mel says, great presentation. Hey, not too many questions. Maybe it's because I went over, or maybe it's because I did a good job presenting. I don't know. But I'm still waiting for more questions. Rodrigo Guerrero says, kudos from Chile. Thank you. I appreciate kudos back. I would love to come down to Chile and give this presentation in Chile. That would be awesome, Dr. Guerrero. So talk to your local society. I want to get down to Chile. Saran, you're sweet. Thank you very much. Again, I want to go back to the Acceleration Ortho Station. So if you want to write down this number, you can find the group that way, but again, it's easier just to ask to join. Why do I want you to join this group? Because I think this is the best way to ask questions. Because if you ask me a question, not only will I see it, but the entire community will see it. You'll have lots of key opinion leaders, lots of people with more experience even than me that can chime in and answer questions together. So show your cases, show your successes, show your questions, and let's do it as a community. So no questions. I've given people a few minutes, so I guess I'm honored by the lack of questions. Must have been good explanation. So I'm going to go ahead and sign off. Again, sorry for me going over. Seems to be a problem I always have, but I've got a lot to say because this is my passion. And so I'll be signing off with that. Thank you very much for attending. Have a great evening.